So welcome, listener, to the Coriel Ortho podcast with me, Tony Wilkinson, foot surgery expert, founding director of Coriel Orthopedic Group. Now, this is a podcast where we delve into everything surgical, medical, and health and wellbeing related. Now, today we're going to be talking about minimally invasive foot surgery. And we not only have two guests from both sides of the Atlantic, but we're also live on Facebook. You'll also be able to download this podcast from Spotify and YouTube and follow our links on our Facebook page. So I'd like to introduce you to my two guests. First of all, we've got Mr. Tommy Chan, who's a consultant podiatric surgeon both at Doncaster and in Derbyshire and Nottingham. Now, Tommy grew up in my department, so he's been kind of forced into minimally invasive surgery, but I think he can probably teach me a thing or two these days. So I'm looking forward to hearing what he's got to say. Welcome, Tommy.
Thank you.
We've also got Dr. Christina Pratt, who's a assistant professor of podiatric surgery at Samuel Merritt University in California. She works in the Bay Area as well as in private practice. And she's going to give us a USA take on minimally invasive foot surgery, which is probably where a lot of it actually began back in the day. So welcome, Christina.
Thank you.
So we'll go over to you first of all, Tommy. So I got into minimally invasive foot surgery kind of with a negative approach to it. So I kind of looked at what people were doing and I was a little bit annoyed by it, if I tell the truth, because I was kind of thinking, how are they getting the results that they're getting when I'm doing it open? And sometimes you find it's difficult even with open surgery when you're manipulating things into a good position. But you try and do something minimally invasively and you've got a tiny little incision, you're just working under x-ray. I found that kind of difficult. So I kind of went into it thinking, you know what, I'm probably going to prove to myself that this isn't the be and all and end all. But I've actually been quite surprised by some of the results and consistently good results. So much so, we're about to publish a paper on our own results which show that it's as good as open surgery. Now, you've kind of got into it as my trainee, but now you're a consultant, you've clearly carried that on. What's giving you the enthusiasm to carry on minimally invasive surgery?
I think a lot of it is because we've always trained to do things open, but actually when there's another way to do something, I think there's always elements of learning and way to explore something. And if we take a fracture, for argument's sake, an open fracture versus a closed fracture, we know that an open fracture carries far more risk compared to a closed. And I think that same analogy lends itself to any sort of bone and joint surgery. And I think this is where the keyhole bunion surgery comes to its own, is that if you can get equally same results with lower risk, why would you not?
Yeah.
And I think that's really kind of continued to push me to go, actually, we should continue this, because my view is that if you see the evidence and the trend it's going, it may well become the so-called norm in the next few years.
Right. Okay. So Christina, from your point of view, I mean, I first heard of it coming from the United States, so there were people doing it then, and it kind of lost a little bit of favour, I think. I remember Tom, one of our colleagues, Tom, who did a lecture at one of the conferences, and he was talking about his experience when he'd been to the States back in the day, and we're probably talking in the 80s, something like that. And he was going on about people whizzing around in the dark with a burr and causing all sorts of damage because, of course, if you can't see the structures that you're operating on physically, you would think to yourself, well, I'm going to cause some damage. How has it changed in the USA? What got you into doing minimally invasive surgery?
Yeah, I would say my entry point is probably similar to yours in the sense that I would look at those x-rays initially and say, terrible. Right? Who would want to see an x-ray like that?
Yeah.
But, I think what really sort of tipped me over the edge, at least admittedly being somebody who was pretty much, quick to the jump for a lapidus for a majority of my hallux valgus cases, is really post-op, is just issues that I had with open surgery post-operatively, probably also in play as my patient population. So, in private practice, I've got a patient population that says, I can't give you 8 to 10 weeks off of work before going back into a shoe. I want to do this. I feel like I need to do this, but I can only do it if I can get back to work, within 2 weeks, 4 weeks.
Yeah.
And so me starting to think about how do I then best meet the needs of my patients and still abide by, standard of care, I started saying, well, I can't be a naysayer if I don't really know. So I started doing a few MIS courses and really trying to look at differences, not only in post-op outcomes, but intra-op obviously as well, and said, okay, I think that this is worth a try. And I think that that's a lot of the way that people in the States are going with it. I mean, we see so much hardware innovation from company after company after company, just consistently, and it's hard to keep up. And so I think that, maybe certain companies caught the eye of some surgeons, pulled them into a cadaver lab, got them a little bit more comfortable, and then started opening them up to MIS as well.
So it's interesting you should say about seeing the terrible x-rays, because I think from my point of view, I mean, we have a saying in surgery, don't we? Treat the patient, not the x-ray.
Oh, absolutely.
And sometimes I look at my post-op x-ray on MIS, and because there is secondary healing, especially with some of the lesser metatarsal osteotomies I do, because we don't tend to fix them. I think you do it slightly differently. The x-rays kind of like don't look as good as I would like. They don't look as pretty as what they do when I've done open surgery. Do you find the same or?
Oh, absolutely. Yeah. Absolutely the same. But I mean, to exactly what you said, we treat the patient, not the x-ray. I think that some younger surgeons in the States, the way that our board certification process works, all of those cases have to get submitted and reviewed in order to become surgically board certified. And so that is, in all honesty, that's a scare away for some of our younger surgeons in approaching or getting into MIS.
So they're frightened of the board seeing their x-rays and judging the x-ray rather than judging the clinical outcome.
Exactly. Yeah. Because that's really all they're getting is just pre-post-op x-rays for review. So that can be a concern for some newer surgeons. But I mean, I think that, focusing on the patient, like you said, and not on those x-rays, they're never going to look pretty, right? They're not healing with absolute stability. There's going to be some sort of ugly bone callus forming, right? They're never going to be pretty. But the outcome incision-wise is a heck of a lot prettier.
And I suppose the one thing I've learned through time, because I've now been doing it for probably 5 years. So I've had the opportunity of seeing patients maybe, a year down the line, maybe they come back for the other foot and we get a chance to x-ray their foot. Because of course, the problem we've got as surgeons is we see them at 6 weeks for an x-ray and then you might not x-ray it again.
Right.
You may just say, well, it's all fine, get back to normal. But you don't see how it's changed. I'm actually amazed at how the bone remodels itself, so much so in some cases where you've done non-fixation surgery, like on a lesser metatarsal, you've not displaced it medial or laterally. It just looks like a normal metatarsal. It's unbelievable how the bone remodels, right?
Yeah, absolutely.
Okay. So the most common operation I think that we do in foot surgery is probably the bunion. The bunion, as we know, drives most of the pathology in the forefoot. And a bunion is essentially where the big toe is leaning inwards, the metatarsal splaying outwards. And as surgeons, what we want to do is push the metatarsal back inwards and bring the big toe back outwards. So we're trying to reverse what's happening. Now, interestingly enough, I personally don't get many patients asking me for minimally invasive foot surgery. One of the reasons why I started to do it was almost a little bit of a fear that if I didn't have that skill set, there would be such a growth in it that patients would come into my private practice and say, well, I want keyhole bunion surgery. And I would go, well, I don't offer that. I'm sorry. I'll either have to refer you to someone else or try and talk them into something that they don't really want. And of course, one of the problems when you're talking a patient into something that you want to do just because that's a skill set, you're setting off on a negative with them. So any slight chance of a poor outcome, they're going to be wishing that you'd done it the other way. So in the USA, you're in private practice, so it's a completely different healthcare system. Are you driven by patient choice, their choice, or is it more your choice what you offer them?
100%. But I mean, I think due diligence as a surgeon, I have to some degree be driven by what I think is medically best for the patient, right? Okay. And I think in full disclosure, I'm probably still figuring that out on a case-by-case basis. Do I think that this is a procedure that really does need a lapidus versus, an MIS and osteotomy? And so I think that patients, though, definitely, I mean, we've got commercials going all the time in the US, right? You need this bunion procedure. You need,
Speak to your doctor about the bunion procedure.
Yes. Yeah. And so we have patients come in literally having watched the YouTube videos with their brochures and their printouts saying, I want this. I've watched it. That's exactly me. This is what I need. And you're right. You start off that conversation then on sort of the negative note or the dissuasion away from or towards what you think may be better. And that conversation sometimes can get really tough because, you get a bad Google review or they're going to go to the guy or gal down the street and find someone who will do it. So to some degree, my experience has been the same in the sense that, I didn't want to sort of be left behind the cart that was running away for MIS as an option.
Yeah. So Tommy, you're just entering private practice. So the mainstay of your practice up until now has been in the NHS. Have you had the same thing? Have you had many patients coming to you specifically asking for this operation? Or again, is it your choice to offer that?
I mean, I've always taken the mantra that we're certainly with the NHS. I try to give the patient every option that I can deliver. And based on the clinical picture is that if I deem that actually the minimally invasive option is a viable option, I can give them sufficient correction and sufficient, I guess, predictability long term, then I'll be happily offer that them. And in the NHS, what's interesting is that we're having the two jobs that I'm involved in as a consultant over two areas. The demographics have been a bit different. So in the Doncaster area, which is a slightly different area to where I am in South Derbyshire, I don't really get asked much in Doncaster, but within the area in South Derbyshire, definitely more so. And like as you were saying, recently starting private practice, there's been at least a good few patients now already have purposely asked me whether I can do an MIS procedure for them. And it's not necessarily just an MIS bunion, but MIS surgery in general. And I think there is, as you probably state, perhaps less so advertised, but there's definitely more and more patient education. People are more in the know now of this other option of doing surgery. Yeah. And they come in asking for that in that sense.
What do you think is driving them? Is it quicker recovery? Do they have this mindset that, I'll be over this in 5 minutes? It's not going to interfere with my life? Because I must admit, if I was going in for an operation, I think I would be an absolute pain as a patient. I wouldn't want to take time off work. I'd want to have the maximum, at the minimum amount of recovery. I'd want to be back at work full time within no time. And there's a real danger in that, I think, because you can just underestimate, the recovery really of any operation. Is that what drives them, do you think?
And I think I totally agree. I think they definitely do. Certainly the premise of such as those coming for a bunion surgery, they think because it's minimally invasive, they are going back to normal tomorrow, sort of thing. Yeah. But
maybe that nothing can go wrong, right? It's shorter, it's quicker, less chance something can go wrong.
And my final point I always tell to the patient is that irrespective of how it's done, the bone is still being cut, and that needs a period of time to heal. And that's where it's important to kind of just, I guess, make sure the patient's expectations are very clear.
Yeah. So in terms of recovery then, what would be your standard post-op protocol in terms of what you would ask a patient to do after an operation like that?
Like a minimally invasive bunion.
Yeah.
For me, typically the 2 weeks will be heel weight bearing, and if they feel comfortable enough, then they'll be back into training after that point. And the idea is can gradually increase their weight bearing activities. Majority of people are about a 6 week mark. If the X-rays look fine, we should be able to gradually up that activity with a view that 10 or 12 weeks, they should be getting back to normal full activity, which includes running and jumping.
Yeah. Christina, what about
you? I've found a huge difference in my younger patients really being able to recover quite a bit quicker, as one would expect. So I'm probably somewhere in the range of 1 to 2 weeks of either cam boot or surgical shoe. Either one is okay. With a return to regular stabilized athletic shoes somewhere around 2 weeks. Okay. Active passive range of motion throughout this entire time. So I want them consistently moving that first MPJ. Yeah, I don't want to let things get a chance to stiffen up, right? If one of our big benefits of doing it this way is preserving that motion. I do have some patients that lean conservative on, I don't want to touch it. I won't walk on it, even though you said I could. And actually, I need them. And for the means of this osteotomy healing, right? And the way that we do it, we need that micromotion and we need them moving.
Yeah.
So I'm really trying to encourage patients to do that if they seem a little bit scared post-operatively. And then similar, as far as return to full activity, probably closer to somewhere in that 8 to 12 week range.
Do you find you get much stiffness compared to open surgery?
Much less. Much less, right? Huge advantage of an MIS approach, right? Sometimes it may make our job harder, at least on the novice end of learning, right? But, I think that's worth the advantage for the patient post-operatively. For that increase in motion.
I mean, my protocol is pretty much the same. I always say to patients, there are 3 phases to a foot operation. Phase 1 is the injury phase. That's when I've put a knife into you and you've got a wound on your foot, whether it be big or small. Takes around about 10 days to 2 weeks for that to heal up. Phase 2 is the acceptance phase. That's where I'm going to say to you, it's going to take you up to 6 weeks to get back to normal. And they'll say, you know what, I accept that. Phase 3 is the frustration phase. And that lasts normally between 6 and 10 weeks. And 10 weeks seems to be the marker for me when most patients from most operations seem to suddenly turn a corner. It's really interesting. When I used to see patients at 8 weeks post-op, There'd be a amount of patients that came in with little niggles and moans about little bits of that. You change it to 12 weeks, it's amazing how that changes. And they come in and say, if I come a few weeks ago, I would have been saying this, but suddenly it's improved. So definitely that does seem to be the case. So when minimally invasive bunion surgery came along, people didn't fix it. Okay. And there's still a few people in the UK that do it without fixation. In fact, I saw a patient the other day in my private practice who was a lapidus level bunion, so huge bunion, had an MIS, no fixation, but unfortunately had developed a complication, complex regional pain syndrome, which can happen after any operation. So it's not related to the bunion per se, it's just the injury from the surgery. But I was absolutely amazed at the correction. Now, I do follow another guy called Jay Morel, who's in Spain, and he does this resolute podology, I think they call it, resolute procedure. And again, it's just 3 tiny incisions. So he has a bunion incision, metatarsal osteotomy incision, maybe an aching incision, and a lateral release incision. Doesn't fix them. And some of the pictures he shows are amazing. Now, most of the complications I get are fixation related. Either the screw is a little bit prominent, or you get a problem with the metatarsal blowing out, so the metatarsal fractures because of the fixation that's in there. What are your thoughts on not fixing a bunion? Would you consider that, or do you always fix them?
I would say I fix them. I fix them 100% of the time. Yeah. And I mean, I'm even in that camp when it comes to lesser metatarsal still, right?
Yeah.
So, to me, there's some comfort and reliability on having that stable fixation in there. I don't know that like I said earlier, admittedly, I'm still sort of maybe on the earlier progression of my entry away from fusion and into MIS. But I don't see what would push me all the way to the edge of not fixing. And maybe fortunately, or maybe it's the fact that I haven't done as many, but hardware irritation hasn't been a humongous problem. I mean, we can talk later about things like the medial shelf and whatnot. That's been a bigger problem for me as far as irritation. So.
Yeah. Okay. Tommy?
I think for me it's that sense of if you got it's having control or correcting a deformity, and the only way to control it is having some form of fixation in there. I mean, I think on balance you can probably heavily strap someone enough and potentially mobilize someone enough, and you may get away with no fixation, but that kind of flies in the face against sort of AO principles.
Yeah.
You want some sort of stability, because the premise of what you're doing, you essentially caused a fracture. So I don't think I would, certainly for the first ray, given the importance of function, that I wouldn't fix it.
Yeah, I'm kind of sitting on that, bit irritated by it again now, because it's like, how are they getting such good results without fixing it? But I know that they do bandage the toe into the opposite of a bunion, so into a varus, and whether that's applying a force retrograde to hold the metatarsal, but they're still kind of getting them back to more normal footwear after 2 weeks, and I'm struggling with it a little bit. So once you have moved the bunion over, you are left with an overhang, the shelf, as you mentioned a minute ago. And there are 2 real ways of removing that: either just burring it off, so filing it down, if you like, and trying to create a mush and allowing that to come out, or to cut through it and either remove it, or what I do now, because once you've removed the shelf, it leaves a hollow in the metatarsal, you can push it into the metatarsal, which actually acts as a little bit of a bone graft, if you like. Sure. Maybe. I don't know whether it adds much really to the recovery or the healing, but what's your preference in terms of removing that overhang, and why do you still get problems with it, do you think?
Yeah, I would say because I'm probably still trying a variety of techniques, really, in all honesty, to find what's best. I started at first rasping, so really going in there with either burr or power rasp. And I think I was probably just being a little bit conservative in the sense of not wanting to compromise that distal screw, depending on where that distal screw placement ended up, or the head bevel of that distal screw. And so I probably just didn't remove enough initially, a little too conservative with the rasp. I have had more success recently making sort of a pilot hole through that medullary canal, right? And then utilizing the burr medially that way to remove. I have not yet used the technique of trying to push that shelf, or, I've tried before even just rongeuring, going in there and just nipping at it. 1, that takes too much time. 2, that was not smooth enough. I think about my patients, majority are, 40s, 50s, 60s, female, bunion patients who come in wanting to go back to similar shoes that they've loved. And that medial shoe just ends up hitting that spot for me right along that medial long axis so much that I really try to pay a lot of attention to how that's going to feel. So, I don't want to sort of rob Peter to pay Paul in a sense of shifting over that capital fragment so they're not feeling that bump anymore, but they crawl a little bit back and now they're feeling a new bump.
So if you do get a patient coming in down the line saying, you know what, Christina, I've still got a discomfort from that bump there, what do you do?
Well, I mean, not many other options besides going back in and trying to revise.
And you do that MIS, minimally invasive as well?
Yeah.
Okay, interesting. So Tommy, what about you? What's your preferred option?
I tend to find if it's if I'm only moving a small amount and it's only a small shelf, I'll tend to would burr. But when you've made a bigger translation or transposition, then I generally have, you obviously got a bigger overhang. Then I generally would osteotomize it, and if I can pull it out, I'll try and pull out with a mosquito or a clip of some sort. But if not, often just some manual direct pressure medially will just helps me push the fragment bone in, and normally just sits in there with no problem.
So if you're going to pull it out, are you pulling it out through the distal stab incision or proximally?
So the same portal that I've gone through from proximal, where I put the bone.
Okay.
And just pull it out.
Yeah.
Okay.
So of course the other bump on the metatarsal, which is the primary bump, is the bunion bump, and I've had minimally invasive surgery because when I first thought about it, the first thing that came into my head when I was thinking about it was, how the heck do you get rid of the medial bump properly? Because when I did open surgery, I take quite a bit of medial bump off. Now, and I always thought that was the right way to do it. But by doing MIS, I've realized that actually you hardly have to remove any medial bump, which means that when I do an open operation that I still do, I remove now much less. In fact, whereas before I used to take the medial bump off first, I now do it last because I don't want to take too much off anymore. So have you found that, has it changed your approach to open surgery by doing minimally invasive surgery? Or do you still just take the same amount of bump off that you would do?
I mean, I'm definitely in your camp because I guess doing my training with yourself, I quickly came to realize actually where I try not to take a standard approach for all procedures. And I think that the problem is when you take the eminence off as an open procedure, then you kind of leave yourself short how much you can move it. Because the risk is if you want to move it to somewhere where you think it's better, the risk is that the big toe's got no medial shelf left. So I've always taken the amount that I only need to so that my sole's not bouncing off it. And what I've found is actually that has translated itself to MIS, where if you get a good a capital shift of that, actually I'm only actually smoothing that email as opposed to burying anything significant off. So I don't find I'm doing lots of that really.
Okay.
Yeah, somewhat similar. In the sense of, there's definitely danger to taking too much, right? Violate that plantar sagittal groove. And, I don't really want to risk varus in my patients. But, I also think if you feel like you need to go in there and really remove a huge amount of it, dependent on what sort of osteotomy or orthodesis procedure you're doing, maybe we should have chosen a different procedure in the first place. Or we undercorrect it, right? We didn't get the positioning that we needed to. If we still feel like at the end, to make it look better or, make it feel better post-op for the patient, we needed to go in and take more.
Okay. And do you feel that you need to do a distal release and an aching with most procedures? Do you combine it with an aching, so a wedge out of the big toe to try and bring that straight? Or do you find that the operation is powerful enough to deal with the deformity without doing that?
For me, I love an Aiken. I think it's a very I see it and I describe it to patients as sort of the fine tuning at the end of the procedure. I've got a lot of patients who will be very unhappy if they still have that 1-2 touch, even if there's no more medial bump, right? Even if that nail looks like it's rotated out of the frontal plane and their toenail is back, straight again, they're still seeing 1 touch 2. And patients don't seem to like that very well. I end up doing a lot of Aikens, whether it's MIS or even whether it's lapidus in some cases.
Okay, Tommy?
I'm very much the same. I very rarely I don't do one. I think there's also plenty of studies talking about doing an Aiken where you help take away some of the deforming force of one of the long tendons that run over the big toe. And I guess it's trying to not necessarily correct the deformity just because of deformity, but all the soft tissue, the alignment of it as in its totality.
So one of the most frustrating conditions that patients come up with is pain in the ball of the foot. And sometimes it can be non-specific metatarsalgia. It's interesting that the patient will come in and say, I've been diagnosed with metatarsalgia. And I say, well, that's not a diagnosis. If you went to your doctor and said, I've got pain in the foot, and he said, your diagnosis is pain in the foot, you would just think he was mad. Well, because we use a nice name to it, it becomes a diagnosis, but it's not. And we think about the anatomy and the parabola, as we call it, the lengths of the metatarsals often as podiatric surgeons, and talk about whether metatarsals are long or others are short. And sometimes it's really obvious that there's a long metatarsal. Often it's not too obvious, but you might look at the first and fifth and think, well, that's a little bit short compared to the second, third, and fourth. And we go ahead and do osteotomies, cut the bone and shorten the bone to try and take the pressure off and lift the bone up a little bit. Now, the operation I always used to use was a Weil osteotomy, so named after Lowell Scott Weil Sr. I think there's now a junior and a Lowell Scott Weil III, so it's obviously really running in the family. I'm thinking about that for my own family, actually. I wish I'd gone down that route, but never mind. But I hate the Weil osteotomy. I don't know about you. I went to the ACFAS conference a few years ago, and Lowell Scott Weil Jr. was doing a lecture called Think a While About the Weil. Which I thought, well, if he's saying he's got a problem with it, then there must be issues with it. And the reason I don't like it is that I reckon at least 50% of toes float off the ground. It drives me insane. And I don't truly understand why that happens. In what I mean by that is that I can do the exact same operation on two different people and they get two completely different outcomes. And it's very hard to predict, I think, whether a toe is going to float off the ground or it's not going to float off the ground. But the minimally invasive surgery doesn't do that at all. I do an oblique cut. So it's kind of one that was described by Basil Halal back in the day, which is just a 45-degree angle at the metatarsal neck, trying to get just on the surgical neck of the bone, not too proximal, but you can get away with a bit more proximal, not too distal because you don't want to chew the metatarsal head up, but right on the neck. And basically, I'll just cut it through and allow it to float. And I do all three central metatarsals normally, unless there's an absolute obvious single metatarsal that's really long, or there's kind of a corn underneath the metatarsal and it's obviously long, then I might do a single one. So you were telling me, Christina, that you fix them. Now, I'm trying to think how I would possibly get a screw percutaneous into a lesser metatarsal in such a small space. How are you doing it? What's your technique?
Yeah, so I mean, I still have, I would say probably at least a 5mm incision.
Okay.
Yeah, on the dorsal
aspect. So it's not truly MIS in the same way as we were talking about before.
Sure, and you know,
semi-open.
This is full disclosure. I hate the terminology MIS, right?
Right, okay.
What is MIS to you, to me, to you, right?
Yeah.
You know, maybe we should really be using more terms like percutaneous.
Yeah.
And so, you know, my MIS may be 10mm, yours may be 8, yours, you know. Yeah. And so I find that, you know, I hesitate to call, you know, some, especially when I'm talking lesser mets. I will approach that though, you know, consistently in the way that I tend to do them isolated, only where I feel needed, versus approaching it across the board 2 through 4. Yeah. And it takes me quite a bit to see, you know, a defect or a difference in metatarsal parabola to go after those lesser metatarsals. I've had more, you know, post-op pain, post-op issues sometimes with that long-term than I have doing the actual bunion procedure.
So are you still using a burr to cut the bone as opposed to a saw?
Usually a 5mm blade.
Right, okay.
Yeah.
And so you're still doing a Weil style
A Weil type, just a little bit more proximal.
Yeah.
I have stayed away from sort of that true violation of articular surface if I can, to hopefully, like you said, speak to a little bit of that floating toe issue. Yeah,
and you do the same procedure as me. So what's your thoughts then? Because it kind of turns everything on its head. I mean, I remember when I was training that my tutor said to me, you know, you can't leave a bone unfixed because bones can't think for themselves. And it kind of made a lot of sense to me at the time. You know, I want it to end up where I leave it. I don't want it to move all over the place. Yeah. But I suppose with the true minimally invasive, so just doing through a stab incision at the neck of the bone and being completely still engorged in soft tissue, it kind of does find its own level. And I've actually been quite blown away with some of the outcomes, especially for those persistent central metatarsalgia that's been non-specific, not really had a true diagnosis with it, not been an inflammation of the joint or an IPK under the metatarsal head or even a neuroma type pain. It's just been a non-specific pain. And they've done really well with it. What are your thoughts on that?
I totally agree with you. I think I'm very, very selective with the open procedure because I've seen those that don't do well, and everyone has these sort of complications with it where people just struggle with pain, and it's just very, very hard to predict those outcomes. And I think the key thing with the MIS lesser met osteotomy is that you don't violate the soft tissue, which you've kind of really hit the nail on the head, is that everything remains pretty stable. And actually the risk of a non-union is virtually negligible because it's no worse than essentially having a stress fracture in that sense. Yeah. Granted, I think because you're not fixing it, there is more swelling. But the default of having how you made the bone cut is that we want them to weight bear on them pretty soon. And the idea is that weight bearing process is what gives you your bone contact.
Yeah.
Sure.
Okay.
So you're putting a lot of reliance on ground reactive force then, and your patient post-operatively doing what they need to do for that. I guess I have a little question in the sense of, as someone who fixates, part of my fear in not fixating is risking transverse plane over time of those toes. The most difficult thing in my surgical practice, I will say, for me, is transverse plane deformity of lesser digits.
So it's interesting you should say that, because the go-to treatment, if somebody's got adducted toes or windswept toes, so adducted towards the big toe or windswept away from the big toe, my go-to is 2-3-4 MIS osteotomy to realign the toes. And it seems to work really well because you get a decompression effect of the metatarsal. And sometimes I will combine that with a small MIS burring, a wedge burr on either the medial or lateral side of the toe, depending on which way I want to fix it. And I don't fix those either. Okay. I mean, it was funny. It was talking to the theatre staff. And I said to them, all this money you spend on fixation, all you need is a set of Steri-strips, cost you about 3 pence, and you don't need anything else. It's come full circle. I mean, for those particular deformities, I seem to do really well and get away with it. Okay.
And that is the same for me in that sense. Because I think when you've got especially multi-digital deformities, is if you start opening them all up, there's a lot of swelling and a lot of unpredictability, and that's it. That which is always the worst in surgery, is that you want to make things black and white as predictable as possible. And I guess by only doing an osteotomy as such, you're not violating anything else. There is elements of, I guess, how good your overall reduction of the deformity is, but then nature will take over at that point. Yeah. Where once you reduced it, your bone will heal in the position that used to be left.
I mean, I must admit, we talk about minimally invasive being less pain and swelling, but I do think that some of the lesser metatarsal MIS that are not fixed do take longer to get over, because you do get some clicking for a little bit of time. Yeah. And it's hard to come to terms with that first when you're not used to seeing that post-operatively with fixed metatarsals. But they do seem to do well over time. And like I say, once you see them a year down the line, the bone's remodeled. It looks like you haven't even been there and done anything. I suppose that the next stage on from doing these sort of procedures is actually going into fusing joints, or doing big toe fusions or midfoot and hindfoot fusions. Now, for me, that's a big step. I've started to do that. I've done a few MTPJ fusions, so big toe fusions. I've done a couple of second MCJ fusions, and now I've done a few TN fusions, so hindfoot fusions. But it's quite daunting. And I think the worry is it's very difficult to know how well you've prepped the joint because you can't physically see it. Yeah. Now, I do the talar navicular joint through what you were talking about, maybe a 5mm incision. And the way that I do that is I map out on the foot, first of all, with a pen under x-ray exactly where everything is, so I can physically see it, because it can be quite disorientating doing minimally invasive surgery, right? Once I've mapped it out, I make a small incision, and then I just put an elevator into the joint to feel the joint, to get a feel of where the bone is. And then I put a distractor on it to gently open it up, and then just burr it down as much as I possibly can. I then do put a drill through the hole and fenestrate it with a drill, and sometimes a little tiny osteotome, and try and fish scale it. Yeah. But I always feel a little bit left, even though it looks all right on the x-ray. You're not quite sure whether you've done enough. And talar navicular is prone to non-union as it is. Right. Now, fortunately, I don't seem to have had a non-union in the ones that I've done. Have you ventured into the bigger fusions with it yet? Is that somewhere you want to go? Do you see a future for that?
Oh, I absolutely see a future for that, right? Especially as instrumentation advances, right? And sort of the ability to get in there with instrumentation, smaller instrumentation, easier. I have not myself started to do, MIS, if we want to call it, arthrodesis procedures, but I definitely see it getting that way. And I think, the reliance then is really on really trusting fluoro. And MIS has taught me that. I am sort of, I want to see it to believe it type of a person.
Yeah.
And so MIS has really taught me to sort of trust fluoroscopy more. But I'm probably not just there yet.
Okay, Tom?
Again, the literature is definitely going there. And for me, the MTP joint fusion, I was saying this morning, is that within the UK, we haven't come across a screw specific that gives us compression yet. And then until I was up literally this morning, where I've managed to meet one of the companies who provide one of these screws. And I think by having, to some extent, that industry that catches up with it will open these doors. But again, you tend to see these trends where as manufacturers innovate more and more different screw fixations, that often goes in trend with these sort of procedures. And I think, again, that's going to be likely the future. Yeah. I was saying earlier within the workshop is that we've always done things open, but you tend to see many surgery in general is going either laparoscopic or arthroscopic or keyhole. And that may well become the primary procedure, the gold standard first. And then actually in time, should you have a problem with it down the line, you need to be revised. And that's perhaps when we default to an open. And it kind of goes against the grain. It's kind of turning everything upside down, isn't it?
Yeah.
But I totally think, that is where it's going to be.
Okay. So I suppose where MIS really comes into its own is in the medically compromised patient in some way, whether that just be that they're obese, whether they've got a lot of swelling, lymphedema, that type of thing, whether they're immunocompromised and therefore there's a risk of infection, or the big one is diabetes, right? So there's lots of applications for diabetics in terms of whether you can treat ulcerations by just doing floating osteotomies, by removing bone that's infected through a smaller portal, through to doing a full Charcot reconstruction where using MIS, which is something I've not quite ventured into yet. What's your thoughts, Tommy, on the diabetic foot then? Where are you at with that?
I'm a real big advocate for it. So my job in Doncaster is probably about 30-40% of it is heavy limb salvage work.
It's growing, isn't it?
It's definitely growing, and it's not so long ago where a patient with a lot of comorbidities, significant lymphedema, it just was one of those patients, if you had a choice, you would not want to open. And that was the scenario where MIS came to its own, where I did an osteotomy of essentially doing an intrapedal amputation for a metatarsal, and then I would remove the infected bone, knowing full well that if there was any fluid in there that was undue, then I could always open it as a backup, but it wasn't. So then we managed to manage a situation that could have been very tricky in keeping the risk to an absolute minimum.
Yeah. What about yourself, Christina?
Yeah, and I think, to speak back to MIS arthrodesis procedures, that's where this can become really helpful, right? Especially when we talk diabetic patient population. But I completely agree. I think that, when we talk about our diabetic patients, being minimally invasive is definitely a strong consideration, if not definitely the way to go in a majority of these cases, knowing that you always have the fallback of, if you absolutely have to open it up, you can.
Yeah.
So, yeah.
Okay. So in terms of the future then, do you see MIS as going to be the mainstay of surgical treatment in the foot? Do you think it will remain just part of it, or is your practice going to end up being more MIS than what it currently is?
I think it's going to continue to grow. I do see this as being something where, we're going to see more and more, if not almost all of us, jumping on this because it's, like you said, it's starting to, integrate into various other procedures besides just elective surgery, and I think even back to the point of diabetic foot surgery, totally different world, right, than elective foot surgery. Yeah. And so I do think still that those get approached with different considerations, obviously. But I think in both of those worlds, we are going to see MIS continue to grow.
Tom?
Yeah, I mean, the mainstay is that is you cause less trauma. I mean, that's a given. And I think where there's a way to improve patient outcomes to reduce that risk, it begs the question, why would you not be going there? And general surgery is a prime example. Everything's laparoscopic now. Mm-hmm. So, and why would be foot and ankle surgery be any different?
Yeah.
If there's a procedure that can give you equal clinical outcomes, radiological for argument's sake, then why would you do it open?
Yeah, and I think I do feel the same. I think my practice has definitely grown. I mean, I did make a bold statement last year at the conference where I was presenting that I will probably not be doing a scarf aching osteotomy in a couple of years' time. I'm not quite sure I'm 100% there, but I am definitely edging towards that. But who knows? Well, thanks very much for your time and your expertise, especially during the conference. And I hope you enjoy the rest of the conference. Thank you very much.
Thanks for having me.
Thank you.